This is Masood Hashmi. These videos which I am putting for you, these are only for educational purposes. You are not allowed to treat yourself. And if you have any symptoms like this, then you should consult your medical doctor or a surgeon to treat you. These videos are not meant that you should treat yourself. Thank you. This is Masood Hashmi. Today we are going to talk about acute appendicitis. You remember in my previous lecture I showed you the anatomy of the abdomen. So today we'll revise it a little bit. So this was the abdomen and these were the quadrants I made: left upper quadrant, right upper quadrant, right lower quadrant, and left lower quadrant. The appendix is in the right lower quadrant. So I showed it how it's inflamed. So basically appendix is arising from the base of this colon. It's called cecum. So this is cecum, and there is a small ball which reaches here and the appendix comes out of here. And this is the blood supply of the appendix. It's coming from ileocolic artery. It's called appendicular artery. So the reason I'm showing this is the thing which we need to be careful in surgery, that we clamp this artery and also we take out the appendix at the base of the cecum. Now we're going to talk about how we diagnose appendicitis. Now we're talking about how the patient presents. Most commonly when the patient comes in, he has abdominal pain, vague abdominal pain in the beginning, usually starts around periumbilical region, transfers to the right lower quadrant. That's the typical appendicitis pain, not always present, but most typical you see. Also, they can have a low-grade fever. Usually fever is not very high if there is no perforation. So low-grade fever between 99 to 100, and also nausea, vomiting. Main symptom which I have seen in children is anorexia, like they don't want to eat, they are not hungry. So if you ask a child, say about 6, 7 years old, 8 years old child, ask him his favorite food, will you like to have hamburger or fries? He'll say, no. So if he says, yeah, bring me, then you doubt your diagnosis, because anorexia is very common, especially in children. Now, presentation, now we do the lab test. What kind of lab test we do when the patient comes to emergency room? So, first of all, we'll do a CBC, a urine examination, and a pregnancy test if it is a female. Don't forget that, because if it is a female, you don't want to start sending him to the x-rays, because if she's pregnant, then you'll be in trouble. So pregnancy test is very important. So these are the basic blood works you do. After that, there are tests we do to diagnose. Most common test nowadays, which we're doing in emergency room, and very diagnostic, also for medical students, is CAT scan. It's 95% accurate. So most of the time, patient with the ER doctor suspects they first of all do the CAT scan. Mostly non-contrast, also sometimes with the contrast. You want to make sure there is no perforation. But the CAT scan is number one. Now, if there is a patient who is pregnant, you want to do an ultrasound. You don't want to do any CAT scan or any x-rays. And if the ultrasound doesn't show, the other third test, also ultrasound, is good for the children. It shows compressible appendix, then it's not appendicitis. So ultrasound also is a very important test. The third test, which MRI, which I have done once in a while, is for a pregnant patient, which I'm not really sure, because you don't want to do these CT scan on these. So MRI and the ultrasound is for pregnant patient. So let's say we got the diagnosis, we did a CAT scan, and it shows appendix is inflamed, there is a dirty fat, there is a localized inflammation, and you are sure it's appendicitis. And then a surgeon comes, he looks at all the lab work, he looks at the abdominal exam. So abdominal exam is so important. You have to see where the tenderness is. Usually the tenderness is point tenderness over McBurney's point. McBurney's point is, it's an important exam question. Here's the umbilicus, is spine, and there's a line you draw, and it's the 2/3 from here, from a belly button, and 1/3 from anterior spine. This area, this is the McBurney's point. And this is the place when I used to do open appendectomy long time ago. This is the place I used to make a transverse incision and go ahead and take the appendix out. So this is McBurney's point they asked you in the examination. So patient has point tenderness. I do one more thing. I tell them to cough, and if the patient coughs and he does like this, it hurts him, I worry about appendicitis. Also, when I push on the left side of the abdomen and I let my hand go, a patient has pain on the right side. My test, most of the time, I examine the right side and look for guarding. Guarding means the muscle gets tense. And with all the other findings present, I think it's appendicitis. Now about when we were residents in 1980s, at that time, 20% time you can make a wrong diagnosis. But right now, in 2022, due to CT scan availability, maybe 3 to 4% people have normal appendix. So CT scan is the #1 test. Then we're going to talk about what are the operations we do for appendicitis. Now we're talking about operative procedures. So #1 procedure nowadays, I think in the United States, is laparoscopic appendectomy. And basically, here's the abdomen, and these are the 3 ports. One is through the belly button, other one is suprapubic, and then there is on the left lower quadrant. So basically your light source comes from this 5 millimeter from the top, and this is from this 5 millimeter you grasp the appendix, lift it up, and then you take out this blood supply of the appendix. First of all, make a hole between this mesentery and the appendix, and take out the blood supply with either cautery, clip, or bipolar source. Then this base of the appendix, we take it out with a stapler. And the appendix is then removed through the bag, through this port in the left lower quadrant. So this is laparoscopic appendectomy. If you cannot do it laparoscopic appendectomy, you can still open and do the appendectomy. So this is laparoscopic procedure. The next procedure is open procedure. So open, here's the abdomen. And appendix, as you know, is in the right lower quadrant here. The incision, we make it over the McBurney's point. After cutting skin, subcutaneous tissue, muscle, you go into the abdomen. Here's the cecum. And you again divide this mesentery of the appendix, clamp, cut, and tie. And then base of the appendix will tie twice. And they take out the appendix out this way. If you cannot take it out, or patient is too busy or it's too difficult, and this is the belly button, you open from midline. And you go and take out the appendix. Now in certain situations, not very commonly, if somebody comes very late and has an appendicular mass, appendix is inflamed but it's all around, is loops of ball and momentum is all around, and patient is not septic, you can give IV antibiotic and then later on do an interval appendectomy. So in order to do this procedure, you have to select the surgeon, which is, you have to select yourself and then see his reputation and then let him do your surgery. Thank you. Let's say we're doing the surgery and the appendix is normal. Then you have to look for what was the reason for the pain patient had. So you need to look for these things. So I made this a diagram for you. Let's talk about a female patient. So you worry about ectopic pregnancy. So that's why I said you need to do a pregnancy test beforehand. And so ectopic pregnancy, then you have an ovary. You could have a torsion of the ovary. You could have a cyst which is bleeding. Very commonly we have seen cyst bleeding from the ovary. So our pelvic infection also very common, you see that. So this is, you must look at this area if this is negative. Also, the other areas you worry about is Crohn's disease. It's like always look at the terminal ileum of the small bowel, see if patient has Crohn's disease. And in Crohn's disease, if the cecum is not involved, you can take out the appendix. So next time you don't get confused. The other thing I've seen it many times that in my early life, and I'm in a younger life, at that time CAT scan were not very good. So I have seen very commonly lymph nodes in the mesentery of the appendix, which really mimic appendicitis. So I have got that mistake before. So these lymph nodes, you worry about it. More other thing we used to do also, which you should do, is look for Meckel's diverticulum. That's about, you look at the terminal ileum, and then you look for this Meckel's diverticulum. Usually, if there is inflamed, you will see the inflammation around it, and then you remove this Meckel diverticulum. So these are some of the points that you worry about if your appendix is normal. This is Masood Hashmi. I'm going to show you the summary of the video I just made on appendicitis. There are certain things I missed, so I wanted to show you in this summary. So first of all, before surgery, a preoperative antibiotics are given. And for a patient who is not allergic to penicillin, I give cefoxitin, 2 grams IV before surgery. And if somebody is allergic to penicillin, then I give clindamycin plus fluoroquinolone IV. So this is very important. And if somebody does not have any abscess, then you don't have to give any more antibiotic. This is just to pre-op. Then Foley catheter. You know, since for appendicitis, this trocar, which is suprapubic, you can hit the bladder. So I usually tell the patient to go to the bathroom for urination, or if they can't, then we put a Foley catheter in to drain the bladder, so we don't hit this trocar, not hit the bladder. Number 3, what are the really causes for appendicitis? The appendix is like a diverticulum. See, it's hanging from cecum down, so it has an opening. So when this opening gets blocked, you get inflammation of the distal portion of this appendix, so you get appendicitis. So what are the causes? Is could you block it by the stool, blockage by this, what we call a fecolith. If you see a fecolith, which is like a stone in the appendix, it's like 100% diagnosis for appendicitis. And then sometimes there are worms which go in, they cannot come out. Like especially in children, there is a condition called follicular hyperplasia, and they get appendicitis like this. And in older people, you get tumor, which can cause also a blockage. So that's why I said before, if somebody is an older person, you worry about tumor also in the differential diagnosis. The other thing I want to show you about this trocars. In the movies, I use this 12 millimeter trocar from here. So sometime when you use Hassan, you can have 12 millimeter here also. So these trocars, this is normally, it should be like in a triangular fashion when you're taking out the appendix. The other thing I was mentioning in the movie about Meckel's diverticulum, this is really, it's about 2 feet from ileocecal valve, 2 feet from here. So you really have to run the small valve about 2 feet to make sure there's no Meckel's if the appendix is normal. And it's also present in a 2% of population. So these are also exam questions for my students and the residents, and I'm so thankful to you for listening to my talks. If you like my movies, then please subscribe to my channel. Thank you.